The neurology board exam is not the easiest test in the world to take, but it doesn't have to be the hardest. And for a test that costs $2,500, it's not one you want to take twice. You'll probably want to buy a good review book or download some old lectures from residency. But let me tell you that none of this will be as comprehensive as the University of Pennsylvania's 15th annual board review course. This 2-day program in Philadelphia takes place June 4th and 5th of 2018, and it can be attended in person or online. It's intended for graduating residents and fellows, but it also provides an excellent review for those of you planning to recertify. So check out what it has to offer at penneuroboard2018.com. And if you're interested, use promo code WAVES2018 to get $150 off your registration fee. Again, the code is WAVES in all caps 2018. Jim Sigler here for another installment of the Brainwaves podcast. In this episode of the Quanta series, where we cover little nuggets of information that give you context for an upcoming episode, Dr. David Coughlin and I will be reviewing dystonia. You remember David from prior shows on the pharmacologic management of Parkinson's disease and in a case presentation for serotonin syndrome last year. Welcome back to the show, David.
Thank you for having me back.
So, what is dystonia?
So, dystonia is thought to be the third most common movement disorder after Parkinsonism and tremor, but it's likely under-recognized given its heterogeneity. And as we'll discuss, the symptoms can be very mild and involve slight muscle cramping, or they can be extremely debilitating. So, dystonia is generally described as a movement disorder characterized by sustained or intermittent muscle contractions causing abnormal or repetitive movements, postures, or both.
Which is an important point to make early on. When I was in training, I thought that dystonia was only a condition that was characterized by stiffness or sustained muscle spasm. But even tremors or other types of movements can be dystonic.
Dystonic movements can be pattern, twisting, and maybe tremulous, and can be initiated or worsened by voluntary action and associated with overflow muscle activation.
What that means, overflow muscle activation, is when you have your patient perform a task, like drawing out letters in the air with the left hand, and the tone in that contralateral extremity will increase.
One of the somewhat difficult aspects of dystonia, I think, is that it can be seen in a variety of contexts. It can occur in isolation or secondary to a neurologic or medical condition. It can affect all age groups and can affect nearly all skeletal muscles in the body.
Dystonia can be a tricky diagnosis.
This is Dr. Andres Deik, an assistant professor of neurology at Penn, and a specialist in movement disorders. You'll be hearing from him in a couple of weeks.
And it can be difficult to differentiate from other similar movement disorders. And I just want to stress on how important the thorough and thoughtful movement disorder examination is in the role of diagnosing this condition.
For the purposes of today's show, we'll just be talking about what dystonia can look like on exam, and what features may help you differentiate dystonia from related disorders of movement.
It's always important when you examine these patients to make sure that you're examining them with their shoes and their socks off and their pants rolled up, because at times the dystonia can be subtle, especially if it's affecting their toes or their feet, and you'll miss it if you examine the patient without their socks off.
Definitely true for dystonia. I would also argue that it's important when evaluating patients with other conditions, like those suspected of motor neuron disease. Catching those minuscule fasciculations during an interview will help you identify that lower motor neuron pathology. But today, we're evaluating patients for dystonia, so let's get back to that. Here's Dr. Deik again.
One of the key elements in the diagnosis of dystonia is to find whether there's any posturing. So posturing refers to the ability for the condition to cause a specific limb or body part to be fixed or dynamic in a certain abnormal posture.
Something like a foot turning inward when you walk, or your hand getting stuck into a contracted state when you've been writing for a while. Writer's cramp.
Now, patients with spasticity can also at times have fixed postures, and that will be the main differential diagnosis there. But in general, when you see a limb or a body part that is in an abnormal position, you have to start thinking about whether the area of the body is affected by dystonia.
This clinical syndrome is probably the most widely recognized, and it's a major reason for referral for dystonia to a neurology clinic. But dystonia is more than just cramping and limbs getting caught up in a position. And as we'll discuss later, when you're diagnosing the dystonia, it's important to recognize whether it's a focal dystonia. Isolated writer's cramp or torticollis would be good examples of this. Or it's a segmental dystonia, meaning it involves several muscles but only one segment of spinal cord innervated muscles. Or a generalized dystonia, meaning multiple motor groups are affected. Knowing which type of dystonia it is will inform you of a diagnosis and definitely your treatment. So when you see that patient who comes in complaining of neck stiffness and they have torticollis, you'll want to look for signs of dystonia in other extremities to rule out a more global condition.
Something else that we see in patients with dystonia is the overflow phenomenon.
That propensity for the muscle groups in one extremity to activate with activation of another extremity.
There is abnormal involuntary activation of a separate sort of distant part of the body. I'll give you an example. So sometimes when we do rapid alternating movements of the hands and the patient opens and closes their hand, you can see that the opposite hand opens and closes on its own as well. Same thing can happen at the feet.
Like with rapid foot tapping or heel striking. And then another feature you might look out for is what movement specialists call specificity.
And specificity of task in particular, which means that the dystonia only comes out when they perform a specific movement or task. And the great example there is writer's cramp.
And here we're not just talking about the soreness of your hand with writing. We're talking about your fingers wringing themselves into an obscure fixed position when you try to manipulate a pen or a pencil, or when you're doing some other particular task.
People like musicians, for example, who practice professionally, or at least a lot, and certain types of athletes, where they can get these types of odd dystonic movements, usually of the hand or arm that is specifically engaged in some type of specialized movement that they've been practicing for many years. For example, a violinist, where their finger hand actually has these abnormal contractions just while they're playing. This is a very interesting.
And the strange thing about all of it is that it's specific to that task.
But they'll be able to use a knife and a fork okay, or brush their teeth okay, or button a shirt okay. And the only deficit will be when trying to write.
It probably wouldn't surprise you to learn that neurologists and psychiatrists historically had attributed these task-specific problems to functional disorders. A kid trying to get out of homework, for example, complaining of writer's cramp, or a stressed-out athlete with Charlie horses at night. The next feature of some types of dystonias will also make you think of something more psychosomatic or functional, but it's a legitimate feature too. It's a sensory trick.
And this one might be the most pathognomonic of all the features of dystonia.
Also called the geste antagoniste.
It really doesn't happen in any other neurological condition.
And what it is
that basically patients realize that their dystonic movements improve by touching or rubbing or pressing on certain body parts that are not necessarily involved in the dystonia.
Meaning that when a patient's leg stiffens out with walking, they can do something like scratch their hip, and it will actually release the dystonia.
We typically see it in patients with cervical dystonia, so patients who have dystonia affecting their neck. They'll notice that the abnormal posture of the neck will correct whenever they touch their chin or their cheek or the back of their head. And it's not by pressing manually on the head and trying to correct the posture. Just the act of touching these body areas is enough to correct the abnormal posture.
Unbelievable, right? Well, when you see it, you'll definitely know. And it's only when the patient does it. So you can't just touch your patient's cheek and their torticollis will resolve. They have to touch their cheek. I know, it doesn't make sense to me either. The next and the final feature seen in dystonia is the specific type of posture.
And I just want to point out that they can be either tonic or phasic.
As in, they could be persistent, or they could be intermittent, kind of like a tremor, which can sometimes make it difficult to distinguish from disorders like essential tremor.
And the key there is to see whether the limb that has the tremulous movements has any of the other features that I mentioned above. Is the limb posturing? Does the limb seem to be improved when you touch it? For example, does the tremor quiet down if somebody touches or the patient themselves touch their hand?
Then there's also something about the dystonic tremor which may help you diagnose dystonia, the directionality component.
There seems to be a specific direction or a net direction in which the arm, because it's typically the arm, wants to pull. And then what you'll see is if the patient moves the arm in that direction volitionally, the amplitude of the tremor will improve, whereas if they move the arm against the direction in which the arm wants to pull, the tremor gets worse.
What you can do in this situation, when you see a patient and you suspect a central tremor, you'll want to check for a null point. Is there a point in three-dimensional space about which the tremulous extremity is oscillating? And is that oscillation uniform, regardless of where that extremity is in space? It's usually the arm in these cases, so what you'll see is the arm being pulled in a certain direction, and as the arm is volitionally moved in that direction, the amplitude of the tremor will improve. But if the arm is moved against that direction in which it wants to go, the tremor is going to worsen. A patient who has a central tremor won't have this directionality component. They also shouldn't have a resting tremor, which your patient with dystonia might have, so be on the lookout for that as well. I know it's pretty quick, but that's all I wanted to cover in today's show about dystonia. Once you've recognized that your patient has a dystonia, what kind of dystonia is it going to be? What's the cause? Is it hereditary or acquired? And how do experts recommend treating it? That's what we're going to cover in the next few weeks when Dr. Coughlin's full interview with Dr. Deik comes out, so stay tuned for that. The senior producer of the Brainwaves podcast is me, Jim Siegler, assistant producer David Coughlin, our knowledge producer is Andres Deik, and fun producer is Erica Mejia. Sound producers are Little Glass Men and our very own Philadelphia String Quartet violinists. For full disclosures about Dr. Andres Deik, please refer to this week's show notes. And that wraps it up for Brainwaves this week. I'm Jim Siegler. Thank you for listening.